So in this short lecture, we will talk about fever and its correlation with two very important drugs, that is your paracetamol and the combination of paracetamol with ibuprofen. Now this combination, most commonly known as Combiflam. So this Combiflam is available in the market. Now, why sometimes we use paracetamol? Okay. However, in some condition we use this combination, right? In order to understand this main question, we need to understand the mechanism of fever at the molecular level. So, we know that fever is caused by pyrogens. Okay, so fever is caused by pyrogen. If there is pyrogen present, there will be fever. However, there is a catch. What catch is it? We will see that. So let's say there was any infection and there is inflammation. Now, it's not necessary that all type of inflammation will cause fever, but inflammation have a power to cause fever, right? All this scenario will cause the immune system to release some cytokines. Now the list of cytokines are huge. Okay, we'll just focus only on the important one. For example, interleukin 1, interleukin 6, interleukin 8, interleukin 168, then we have TNF, tumor necrosis factor, and interferon, right? All these are considered as pyrogen. In the whole list, the most powerful pyrogen, this one, it has a tendency to cause fever so much. Interleukin 6 has a moderate type, right? Then we have interleukin 8 and TNF alpha. Among all of them, very important one that if you can remember, you can remember that interleukin 10 has antipyretic property, right? Then TNF alpha, this also has very high power to cause fever. Interleukin 6 has a moderate, right? So again, the most important one among all of them is this interleukin 6. When this pyrogens come into the body, when it is released into the bloodstream, it has main function to cause the activation of COX enzyme. Activation of COX enzyme, in particular COX-2. Now in this upcoming lectures, I'll talk about this COX enzyme when I'll talk about the NSAID, where we will know that there are about several different types of COX enzyme, in particular COX-1, COX-2, and hypothetically right now there's also COX-3. Right, so the COX-1 is more for housekeeping functions. COX-2 is for inflammatory conditions, like this one that we're talking about right now. Right? So, assume this COX enzyme as a ball with an active site. Right now, let's say a triangle, and this triangle is all these cytokines. Okay, this thing will fit very, very perfectly and causes the activation, right? This causes the activation of COX enzyme activation, right? Once it's activated, it will progress the arachidonic acid pathways, right? And once it is activated and arachidonic acid pathway function starts, right? Now this activated COX enzyme can happen, or it can form in two different areas, peripherally or centrally, right? Activation of COX enzyme peripherally will cause activation of arachidonic acid pathway, and it will lead to formation of molecule prostaglandin, that is your PGE2. PGE2 is very, very potent pro-inflammatory molecule. Pro-inflammatory. There's also one more, PGE1, which is anti-inflammatory. Centrally it can reach, right, this activated COX enzyme, and over there then it can produce prostaglandin E2, right. Over there also it got two main areas, over there, and it can reach over here as well. Over here also it will cause formation of prostaglandin E2, right. Now it depends. Let's say there is a man, okay, he got a cut over here, let's say a bleeding, small bleeding, okay, and the inflammation was not severe, so the patient may not even have fever. However, there's a thing called as subthreshold pyrogen. Subthreshold pyrogen. We'll come on this thing shortly, right. So two things: central, which is your brain and spinal cord, and the peripheral areas, right, to where the COX enzymes work, and the output overall is same, prostaglandin E2 in peripherally and centrally. Once in periphery, it can go into the blood vessel, right. It can reach toward your brain by crossing the blood-brain barrier, right. This is a blood-brain barrier, and this molecule will come up over here, right. And within the brain, okay, we have hypothalamus, right. We know that hypothalamus is the main center that causes the fever, but how? Hypothalamus has receptors for this PGE2, right. Let's say the receptor is somewhat like this, like a hook, and all these prostaglandins which came from centrally and from the peripherally by the blood vessel, they will come and act over here, okay. Once it will attach to that receptor, okay, once it attaches, it causes its activation, and it leads to fever, right. Now what is this green color receptor? Now this green color receptor is the EP3 receptor, okay. It's very, very important. Now the fever progression will depend upon several factors, okay. How much the fever will be in the patient will depends upon several factors. First factor, fever factors. Factor number 1, let's see, if there is huge amount of infection, huge amount of inflammation, okay, high infection or inflammation, or high inflammation, maybe there is no infection but there's inflammation, there can be several factors, right, which can cause the same condition. In all those situations there will be fever. Second of all, there is high amount of cytokine release, cytokine, in particular the pyrogens, okay, that is high amount of pyrogen. Third case, let's see, if there is huge amount of PGE2 production, huge amount of prostaglandin E2 production, okay, then we'll come on the EP3 receptors. EP3 receptor. If EP3 receptor has two things, okay, let's say the number of receptor is so much, okay, so huge amount of PGE2 can act on huge amount of EP3 receptors, and resultant will be high fever. and how much sensitivity, okay, sensitivity of the EP3 receptors. So all these situations actually functions to cause the high fever, right? So in our body there is this bar, okay, which we call as a set point, okay. So this is a type of set point, very vaguely used in the physiology of fever. So in set point, in normally in our body we have normal thermoregulation, right? Whenever the body tends to heat so much, okay, we used to sweat a lot in order to cool the body temperature down. However, in certain situations, when there is huge amount of infection and inflammation, huge amount of pyrogen release, so it depends, okay. Let's say this bar is your pyrogen concentration. The black one is the threshold, okay, which is your hypothalamic set point. Over this side is your fever. It's like, let's say it is a 98 Fahrenheit, until the limit is like 105, 106, and beyond that. Patient can even die in certain situation, right? So 90, 99, 100, 1, 2, 3, 4, 5, and 6, right? Right. Now you might have noticed that few patients, whenever they get fever of like 99 Fahrenheit, they're like totally bedridden. Some strong fellas or girls or whatever, even in like 103, 104 degrees, they will act completely normal, okay. They will have mild discomfort, but their fever will be still 104, okay. So the fever, so it totally depends upon how the patient's fever is actually affecting them. It totally depends upon how this prostaglandin E2 is acting on the number of receptors, or whether it is highly sensitive, less. So sensitivity can be even in two types, okay. Even the receptor is so much, and all of them are completely sensitive to all the pyrogens. Some are like, okay, out of like 100, like 20 is extremely sensitive, and some are like vaguely. So overall what happens is like high fever but less systemic side effects, right? So now we have an infection or inflammation, there is increased amount of pyrogen concentration. Now as this pyrogen concentration will shift toward the right and reaches over here, right? We just said there was different sets of pyrogens, 1, 6, 18, and alpha. Right now just assume it as a interleukin 6, because this thing is like everywhere. Interleukin 6 is responsible for so many stuffs. For example, the patient will feel fatigue. Let's say the patient didn't hit 98 Fahrenheit yet, but the pyrogen concentration is increasing. Pyrogen concentration keep on increasing. After a certain point, let's say this point is over here, the patient will start to experience fatigue, malaise, weakness, tiredness, whatever, muscle aches can be there, right? At this particular level, all of this thing will start, and it will continue, okay. This thing, okay, will start and continue till over here, right? And once the patient reaches this threshold limit, where most of the EP3 receptors are activated, right, the patient will start to have fever. There will be peripheral vasoconstriction, central vasodilation, right, and overall the core temperature will start to increase, and the patient will start to experience this fever. Now as this red bar, the pyrogen concentration will shift over here, here, and here, depending upon how severe the condition was and how severe the body is actually responding. Okay, it will depend upon that. Now sometimes it happens that let's say a feature of corona. In the corona time, most of the people had fever. Most of the people even did not even experienced malaria or something else. So totally depend upon how well their immune system is. Let's say their immune system is very well, patient does not need fever, because in fever core temperature increases. Why? It assists immune system to work well. At the same time, it decreases, okay, the habitat where the microorganisms grow, So overall, fever is nice for us, okay, it helps. However, huge amount of fever, 103, 104, not nice, okay. So if a patient has like less fever, mild fever, so understanding is like this way. Pyrogen concentration is directly proportional to fever. Let's say 100 pyrogen concentration, it will be mild fever, 200 moderate fever, 300 and beyond extremely high fever. Okay, so yeah, now let's talk about the concept of paracetamol and ibuprofen and combination. So let's say we have a scenario. Patient came with like mild fever. We gave him like 500 mg paracetamol. Works very well. Patient is good, healthy, right? He thanked you. Okay, the doctor very brilliant. Okay, next time the same patient comes with severe infection. Okay, no, not severe, let's say a moderate infection and inflammation. There was a moderate amount of fever. You give this time 500 milligram, again PCM, but this time he's not responding well. He's like, okay doc, my fever reduced a little bit, but still I have fever and I'm not feeling well. So next dose you increase up to 650 milligram. Okay, he starts to feel good, but still not completely, because the paracetamol molecules and pyrogen concentration, assume it like this. Let's say 500 milligram was acting totally on pyrogen concentration of like 100. Okay, just tentative data. Okay, so 500 milligram was completely destroying all this 100 mg of pyrogen concentration, and the patient has no fever. Okay, next time the concentration went to about 200, right? Not milligram, sorry, 200, and you still give like 500, but we know that 500 was destroying 100. So in this case, still 100 is left, and 100 is still causing the fever, the mild fever. The patient might have 99 Fahrenheit. Next time you increase the dosage to 650 milligram. Now they are taking care of 200, so patient does not have fever at all. So patient is having all these things, 650 milligram. Now third case is that patient have severe form. Okay, and you start with 500, he did not respond. You started with 650 milligram, he did not respond. So you increase the dosage to like 1, 2, 3 and 4 times of 650 milligram of PCM, about like every 4 to 6 hours. So maximum you can go with like 4 gram per day of paracetamol, right? Patient has a little bit of relief, but still he's not acting completely fine. So what actually is happening is that paracetamol and ibuprofen come into play over here. Paracetamol has main 3 things, and over here also main 3 properties. First is antipyretic. Both of them are antipyretic. Analgesia. Ibuprofen also have analgesia, anti-inflammatory properties. Ibuprofen has also the same. So why sometimes we give ibuprofen with paracetamol and sometimes we only give paracetamol, right? So the thing is that all these three properties in both of them are very very nice. Okay, both reduces fever. Okay, ibuprofen is much more little bit better in this case. Analgesia, nice analgesic. Okay, anti-inflammatory, paracetamol is about none to what little bit of anti-inflammatory properties is present. Okay, ibuprofen is still highly anti-inflammatory, right? Now the thing is this over here is that paracetamol acts centrally and ibuprofen works peripherally, as well as it's a COX inhibitor, right? Now if you remember these two things, we are sorted. Now let's come over here. Now let's say the patient has huge amount of inflammation, okay, or infection which was coming, let's say, from this foot, right? So everything, doesn't matter whether the problem was in CNS or in the periphery, everything will go ultimately to the CNS to cause the fever, right? So by the giving paracetamol, we actually decreased, right? By giving paracetamol, we decreased this part, right? So there was production of prostaglandin E2 in the brain, it shut down, right? But still in the periphery there was inflammation which was constantly producing this prostaglandin E2. By the blood vessel route it came up, okay? So we just shut down this thing by giving paracetamol, but still a considerable amount of PGE2 was coming from this pathway, okay, and was causing activation of EP3 receptor. So this was your EP3 receptor and it was causing the fever. So what we did the next time is we started the ibuprofen in this. So ibuprofen is a very potent NSAID, in particular the COX inhibitor. It's a COX2 inhibitor, right? A non-specific one, so it affects both 1 and the 2, right? So then there is also a particular COX2 inhibitor. It is not a particular one, it actually inhibits both COX1 and COX2. So right, here at this step, okay, at this step it was inhibited by ibuprofen, right? So ibuprofen totally shut down this pathway and this pathway as well. So ibuprofen is a very important drug for fever, right? It totally shut down this production centrally and peripherally. So why can't we single-handedly use ibuprofen, right? We can use, but ibuprofen most potently act at the peripherally. So we have to put something with the combination, which has to be the paracetamol, right, to take care of the things present centrally, because centrally there's one more hypothetical enzyme which is the COX3, right? Ibuprofen works peripherally better because it decreases both COX1 and COX2. However, in centrally, once this cytokines will reach centrally, it will cause activation of this COX3 enzyme, and this COX3 enzyme will produces this PGE2. So here the paracetamol works nicely, right? So we add up the ibuprofen in the combination to take care of periphery as well as centrally. Now one question comes is that we can also use ibuprofen alone irrespective of this thing, okay? Even in like mild amount of fever, we usually go with the first line treatment of the paracetamol rather than the ibuprofen, because paracetamol is considerably more safer, because remember that ibuprofen is a non-specific COX inhibitor, okay? So it's a non-specific COX inhibitor, so it affects both COX1 as well as COX2. COX2 was little bit bastard type. It was causing all the inflammation. The COX one, however, is a housekeeping one. Housekeeping, right? And one important function in our body is this maintenance of the gastric mucosa, right? Which protects the stomach from HCl, right? So whenever we shut down this thing and this thing, COX-2, okay, good for us in condition of infection or inflammation. However, giving ibuprofen alone will inhibit COX-1 as well. So overall, this gastric mucosa lining will shut off and overall bleeding will start to occur, right? Patient can experience stool, bloody stool. It can even vomit blood. There will be huge pain, excruciating pain can be there, and so and so. So if we have options available as a first line treatment for fever as a paracetamol, we go with paracetamol first. Increase the dosage to about 500 milligram, 1 time, 2 time, 3 time, up to 8 time you can go with the paracetamol 500 milligrams. Then you can switch to about 650. It all depends upon how much the fever is, okay? If the fever is so much, start with the high dose directly. Go with 1 dose, second dose. You will realize that even giving the first dose of 650 milligram, their fever should come down tremendously. But if it is not, you can suspect that the fever is either so high or the source of fever or the source of prostaglandin E2 production is coming from somewhere else rather than centrally. So we can, at that particular moment, we can add the ibuprofen. Now one thing while giving ibuprofen is that because it's a non-specific NSAID, it will inhibit COX-1 as well. So you can combine it with PPI, any PPI, particularly the moderate potency will work over here, right? For this case, we can add up with this combination, Combiflam, right? And the patient will be good. He will thank you. You're a very, very nice doctor, right? So yeah, this was the main concept that we need to remember, that why sometimes paracetamol work, why sometimes the Combiflam works, right? Why sometimes 500 milligram works, why sometimes 650 milligram works. It all depends upon the concentration, right? Concentration of the pyrogens and the cytokine production. How much the prostaglandins are actually formed, right? Whether it's a peripheral production or a central production or combined of both, right? So depending upon that, we can suspect which drug needed to be given when. However, while giving ibuprofen, one thing remember about the patient is the comorbidities. If the patient have some comorbidities, in past he has some experience, some bad reaction with ibuprofen, switch to some other drugs in this condition, right? So yeah, this was all about this important topic of fever and paracetamol, right? So very, very important thing for us. Yeah, thank you for watching.